to the Public Health Practice Grand Rounds for August 2009. My name is Molly Mitchell, and I'm the coordinator of the Mid-Atlantic Public Health Training Center. And on behalf of the Training Center and the Department of Health and Mental Hygiene, I'd like to welcome you to our presentation for this month on the living in the emergency department, frequent users, homelessness, and the role of the public health community. Before we begin our presentations today, I'd like to invite you to visit our website to view our upcoming trainings, which include Leadership That Gets Results with Kay Edwards, How to Use Social Networking Sites to Advance Public Health with Miranda Ward, our Core Competency Training Series with Dr. Carolyn Fowler, Advanced Advocacy Training with Glenn Schneider, and next month's Grand Rounds on Social Marketing and Public Health, Effective Campaigns and How They Work. For those of you who are watching online, if you are watching with a group of colleagues, we ask you to please fill out our quick survey to let us know so we have a better idea of how many people are watching today for our federal funders. And with that, I'd like to go ahead and introduce our first speakers. Or actually, both of our speakers are going to be working together as a team today. We have Barbara DiPietro, who earned a bachelor's degree from James Madison University and was a Peace Corps volunteer in Malawi, where she worked in maternal child health. After returning to the U.S., Dr. DiPietro earned a master's degree in policy sciences with an emphasis in organizational management, and then a doctorate in public health policy from the University of Maryland, Baltimore County. Her doctoral dissertation examined the impact of homelessness in Baltimore City's emergency departments. While earning her master's degree, she worked at the Office of the Maryland Governor, examining policy issues related to health, aging, and human services. From there, she moved to the Maryland Department of Health and Mental Hygiene, where her major focus was interagency child and family policy, developing the state's 10-year plan to end homelessness, and developing policy and legislation related to core public health services. At this time, she is the Director of Policy for both the National Health Care for the Homeless Council, as well as the Health Care for the Homelessness of Maryland. In this role, she is able to focus on federal, state, and local policies that affect individuals experiencing homelessness, and takes a particular interest in how our current health system is best able to serve vulnerable populations. Our other speaker today is Dr. Stephen Schenkel. Started his medical training at Harvard Medical School, where he concurrently earned a master's degree in public policy at the John F. Kennedy School of Government. While there, he took part in the planning of an executive session on medical error and patient safety, which brought together healthcare CEOs, government leaders, and academics to focus on what was then a newly recognized problem. His thesis on patient safety and medical error in emergency medicine led to an article that the American Board of Emergency Medicine recognized as one of the 20 lifelong learning articles in emergency medicine for 2004. In 1999, he headed to the University of Michigan for a 4-year residency in emergency medicine, serving as chief resident during his final year. In 2003, he joined the Faculty of Emergency Medicine at the University of Maryland with primary clinical duties at Mercy Medical Center. He became chief of the Department of Emergency Medicine at Mercy Medical Center in 2007. His interest in patient safety led him to work with the Maryland Patient Safety Center. He served as chair of the Maryland Patient Safety Center's Emergency Medicine Patient Safety Collaboration from 2005 to 2007. In addition, with the Maryland chapter of the American College of Emergency Physicians, he has worked towards solutions for Maryland's challenges in access to care and medical malpractice. He is a member of the Public Policy Committee of the Maryland chapter of the American College of Emergency Physicians, chair of the Public Relations Committee, and more recently, treasurer. He received the Maryland chapter's Emergency Physician of the Year Award in April 2005. In his clinical role at Mercy Medical Center, he instructs residents at the bedside. He co-directs morbidity and mortality conferences for the University of Maryland Emergency Medicine Residency and has lectured regionally on both patient safety and care of the morbidly obese patient in the emergency department. He serves on the editorial board for EP Monthly and is one of 4 editors of the recently published book, Patient Safety in Emergency Medicine. And with that, I'd like to turn it over to Dr. Schenkel and Dr. DiPietro.
Thank you so much for having us here today. We'll get right into the theme of the presentation today is living in the emergency department and looking specifically at frequent users. And just to give you a flavor for where Dr. Schenkel and I are coming from, I think between the two of us, he brings more of a clinical and operational perspective of what's actually happening with patient care in the ED, and my perspective is more of a policy and public health perspective. So between the two of us, we can be giving you a number of different perspectives on some of the clinical presentation and policy solutions we'll be talking about.
For the introduction. It's a delightful introduction. I'm delighted to be here. I appreciate the invitation. One of the things that I think is so special about this that I was just learning about is this effort to bring the policy side and the academic side to practice and practice to the policy side. And hopefully we actually represent a little of each in each of us and can work on bridging that. Want to give you a little bit of a roadmap, and even before doing that, I want to say I'm delighted to have an audience on the web. Also delighted to have an audience here in front of us, so thank you all for making the trek downtown here. And to warn the audience that's in front of us that we may be lobbing a couple of questions or thoughts your way and ask you to return them. What we're going to do is we're going to take a look at a few initial questions, the background here. Why look at homelessness? Why frequent use? Why now? Want to review quickly what we already knew before the study began, and then take a look at the actual study, the data, and what we've learned in Baltimore. To personalize it a bit, and obviously we're under restrictions of personal data that we can reveal, but we want to try to give a picture of the individuals that we're talking about, take a look at some recent literature, some solutions, and then we're going to ask for your thoughts and your questions. And on the next slide, they're going to give you an email address, which as we go along, if you have any questions or thoughts, please send them to this email address. Obviously, if you're in the audience, you don't have to send them to the email address. We'll repeat that at the very end, too.
So one of the things that you need to ask yourself to begin with in looking at a frequent user population is, why examine homelessness? What specifically about that characteristic makes that a pertinent question to go along with this population group? And one of the things that a warehouse of research demonstrates is that individuals experiencing homelessness have got disproportionately high rates of chronic and acute illnesses across a range of issues, both behavioral and somatic health, as well as rates of disability that are much higher. So you're looking at more of a chronically ill population that would, by definition, be either in need of or using health services at a higher degree of frequency than the general population. But on top of that, what you also see are unmet other human needs, such as a lack of shelter, food, clothing, hygiene, all of the things that go along with just maintaining one's daily living that are not otherwise able to be provided when you're either living on the street, living in and out of emergency shelters, or in other patchwork circumstances. So these are a couple of the factors here that lead us into why, in particular, this issue. And one of the things, too, in coming to this, when I was doing a number of interviews with clinical staff in the various emergency departments, asking them about their issues with efficiencies in the ED, some of the issues in general that they were seeing with their patient population, one of the themes that consistently came up was the frequent user population. And it seemed synonymous with that in that discussion was homeless, frequent user homeless. And that was always a co-occurring terms that were being used. So one of the things that we were trying to set out is, can we try to delve a little bit further into that frustration, looking at systems issues as well as the population, to try to get a sense of the anecdotal belief that homelessness and frequent use were indeed the same population. Is that true? And what could we tell by the data that was available to us using the systems that currently collect the data that we would need in order to answer some key questions? So what's the problem? Again, we had some anecdotal interviews, homelessness being synonymous with frequent use, but there are also some clinical observations that Dr. Schenkel would be in a better position to be able to illustrate from his experience.
So there's, anybody doing research brings to it the question of what is this research going to do? How am I going to apply it in the real world? And part of applying it in the real world is garnering attention. One of the advantages of that, you get some attention, you get some resources, and you get on the front page, right? Recently, several times actually, there have been comments about frequent emergency department use. It hits something in people's souls when they say, this person was seen in the emergency department 1,000 times in 3 years. Somehow there's some face validity to that. There's something unusual, and it gathers attention. The challenge of focusing on a problem that way, of course, is it arrives at the question very quickly of, okay, so what is the problem? We're trying to look at this intersection between homelessness and frequent emergency department use. The question very quickly becomes, okay, is the challenge here homelessness? Is it frequent use? We start with this idea that a small number of patients come to the emergency department frequently. We can look at the cumulative impact. We look at the frustration at a clinical level, because taking care of someone over and over and over for a practitioner is enormously frustrating. The actual effort in any given visit may be minimal, but the cumulative frustration is significant. I'll mention this probably again when we look at times of presentation, but I can tell you that I'm regularly visited by our night folks who will comment on the various presentations of frequent visitors and comment on whether or not it's not time to stop working at night or to stop working in the emergency department. So the ramifications, both from a personal point of view as well as a system point of view, are large. But the result is we wind up with this question of, okay, where does the problem actually lie? And we'll turn back to that too in a bit.
And then in addition to that, what you'll have here is a number of people who are coming in and over and over and over again. At the end of the year, you have invested a tremendous amount of resources, clinical time, all of and yet the patient continues to present, with the idea being that the needs that the patient needs to get filled are not ultimately able to be addressed within the ED, or are not solely able to be met in the ED. And so that's one of the underlying questions, is how are we going, what's really going to work here? And as Dr. Schenkel said, what's the real problem that you want to answer?
So, start for a question. Why the ED? I have an audience here. Who in the audience, and this is a disproportionate sample, but has been in an emergency department in the last 2 years? Well, okay, maybe it's not disproportionate, about 60%. Quick sampling. Why the emergency department? It's quick. Wow, where did you go? You don't have to answer. You don't have to schedule an appointment. I love it.
Just a lot of pain that needs to get taken care of.
Okay, had a problem. Need to take care of it now. Someone over here.
Oh, I work, so I work there at the hospital, so I was in there.
You were there anyway. I love it. It's actually interesting. Hospital employees come to the emergency department more often than a lot of other people because it's easy. Anybody else? One more.
I was just shadowing.
You were shadowing. You're going there to see what it was like. Okay. So, but look at the answers here, right? It's convenient. It answers a question immediately. It's relatively quick. And what do we mean by that? So, let me take an example. Someone with abdominal pain, okay? Non-specific abdominal pain, it's been going on for a while, it keeps coming and going, it's getting worse. You can go see your doctor, you're insured, take everything together. You can go see your doctor. You'll probably get scheduled for one test, another test, a CT scan, you'll come back for results. Could take a month or two. You come see me in the emergency department, I'll do it all in 4 or 5 hours. And you'll have answers to every single test before you leave. So my question would be to turn that around. Why not? Insured or uninsured? Why not? A couple other elements there. We can provide, to some degree, shelter, food, medical care. We do it 24 hours a day, 7 days a week, 365 days a year. We are prohibited by federal law from asking questions about your insurance before we get things moving. Insurance, no insurance, ability to pay, lack of ability to pay, our doors are open. So why not the emergency department?
one of the things in going into this is what is it that the literature already shows us about frequent users in general. And we tried to do two things. And it seemed to be there's two subsets of the population, and the peer-reviewed literature kind of goes in two different directions. There's one section of literature that looks at frequent users. There's another section of the literature that looks at homeless use of health services in general. So we were trying to marry together and see what common themes there could be. As you might guess, in the frequent user literature, there's varying definition of frequent. There's no one definition. So frequent you can set at any point. You can set it at 3 visits or more within 3 months, a certain number of visits over 2 years. So the literature varied. But one of the things that it was consistent on was it tended to be male, tended to be single or divorced, tended to have lower education attainment, generally either high school or less, tended to be low income, tended to have demographics associated with isolation in some way, either living alone, perhaps being alone. These are some of the characteristics that would play out when there were interviews available. Other literature suggested that they just used the administrative data on race and age and those types of things. But when you're working in varying geographic locations, the literature can be all over the place. So just the general demographic population of Baltimore City is going to be very different than that of Kansas City or a rural hospital somewhere. So you have to take things within the context of the community that you're serving already. But in general, what you see are very high clinical needs. Frequent user population is, by definition, a sick group, and they do need care. And they also show that the frequent users of EDs are also frequent users of other health services. So this isn't just perhaps an ED issue. It may be more of a systemic issue, but that is one avenue of spilling over into the ED. You have different patient and clinician perspectives. As we've talked, there's this incredible frustration from the clinical standpoint of not being able to feel like you're making any headway medically. From the patient perspective, some of the qualitative literature shows that this is a family-like place that they can go where they know people, there's a familiarity, there's a sense of safety, security. You can get a lunchbox. It meets the basic needs that we talked about. Why not go to the ED? Everything is there, and we advertise on billboards, come to the ED. So there's a lot of things in play there. One of the things that the literature is mixed in the urgent versus non-urgent care, where some studies will show that there's a high degree of a very urgent care being given to the frequent user population. Others show a little bit more of a mix, and we'll talk about the triage as well. Admission rates, mortality, survival analysis. Again, we're talking about a sick population group with a lot of chronic needs. So you will find that once a frequent user, not always a frequent user, because there's actually quite a high mortality associated with this group. Admission rates into the hospital tend to vary depending on what the survey is and how it was constructed. So some will see a higher inpatient rate, some will see a lower, just depending on how it was structured. But then when you look at homelessness and their homeless groups' use of the ED, what you'll see again is identifying housing status across a broad spectrum while in the emergency department is very difficult from a research standpoint. Unless you're going to walk around with a clipboard, and there have been studies that have done that, but you don't get the whole population group. A lot of the research has to, by definition, screen out people who are unconscious, who are in psychiatric illnesses that don't allow them to be able to participate. You have people who are there who are ill and aren't interested in participating in a survey that might be walked around. So there's a lot of different populations that are not captured when you try to identify status in the ED. Hence, what you see in the literature is the surveys will be taking place at homeless service locations, in soup kitchens, at homeless shelters. And so when you have that setting, you're able to do more in-depth interviews with homeless clients, but at the same time, you're not then able to extrapolate that data to more of the general population, because you're going to get, by definition, a skewed population since it's only that one population you'd be looking at. But with that acknowledged, what you see is you've got high use of the ED by homeless populations, people who are using the ED as their primary care source, but you'll also see very high rates of uninsurance with individuals experiencing homelessness. Contrary to popular opinion, Medicaid does not cover all low-income people. And so what you'll see, particularly in the male population, you'll see a lot of very high rates of uninsured homeless folks. So what you'll have, though, is a largely, depending on the study, older, middle-aged group. Again, you see both men and women, but disproportionately men. And Race tends to vary depending on the geographic location of the study. Education levels, again, that tend to be lower. Income that tends to be lower, very high clinical needs, and again, frequent use of a number of sources. So we used that as a springboard for how we would craft what we're calling the Baltimore study, and how we would be able to unite both this literature and take a look at the data that we have access to. There were 3 hospital EDs that we used in our study, all within a walking distance of one another. So you have an ambulatory care route, actually, that you could walk between these 3 hospitals with very little difficulty. And what we did see actually was that you could see admission rates for the same patient having the same admit date in different EDs, because again, you're able to walk through that. We defined frequent user for the purposes of this study to be anyone who visited 10 times or more cumulatively, but had at least 3 visits at any one of these EDs. So we were trying to screen out someone who might just hit once at it, but then cumulatively, so they would not be captured. But again, 10 total visits. And we assigned a unique identifier that had been previously approved that contained a number of demographic, partial social, partial birth, to allow us to be able to identify within a 99.7% accuracy who that person was. We used only adults. There was no pediatric clients in the study. And at the same time, we assigned the same unique identifier to all the public shelter users during calendar year 05 and to clients that were using the services at Healthcare for the Homeless, hoping that we could capture the homeless services system to the degree with which it was possible to do as a proxy for homelessness. And then what we did was we matched those IDs. So in the end, what we had was the full frequent user ED population. And then we could, by matching to the homeless services population, we could tag ED user presented in the homeless system or ED user did not present in the homeless services system. So it was in that way that we were able to get a proxy for housing status across a larger population group. Now, of course, you're going to have some limitations. You're always going to miss some folks. The city maintains a database of all the shelter users. Not all city shelters feed into that system. In fact, there are two large men's shelters that do not. So we know we're going to miss some folks, but we're hoping by including Healthcare for the Homeless, we were able to pick up some of that extra. And then we made comparisons along a number of clinical factors, comparing the frequent use of homeless patients and the frequent use of non-homeless patients.
Oh, I want to comment on that. I also want to recognize a few people in the audience and make a comment there. It's a little intimidating, actually, given the audience members who are here. I'd like to recognize Kevin Lindemood, whose work with Healthcare for the Homeless is nothing other than extraordinary day after day. I'd like to recognize LaTanya Townsend, who's working in the Mercy Medical Center Emergency Department day after day, is also extraordinary. And I don't know everybody in the audience, but I think those two, both of you represent what this is about. You also represent a whole lot more knowledge than I have as one of the speakers here, which always can make it a little intimidating. With that in mind, a question for a couple folks in the audience. What is homelessness? How do we define it? The white shirt, glasses. Any thoughts?
Someone without permanent shelter.
Someone without permanent shelter. Okay. One more thought. Striped shirt, right back there in a line.
Well, it can be a matter of choice, personal choice.
Maybe a matter of personal choice. Interesting. Probably most studies look at it that way. Are you homeless? Are you not? It's self-reporting, which has challenges. For example, I was living in an apartment until yesterday. The landlord kicked me out because I haven't paid my rent in 4 months. Homeless or not? Yes? Say I'm going to stay with my aunt tonight. Homeless or not?
Yes.
Okay. I've been staying with my aunt for a month. Homeless or not? Sometimes I stay in my own place. Sometimes I'm on the street. All those qualify? Stay with my parents. 23, I live with my parents because I got kicked out of my apartment. Homeless, not homeless. 35, I live with my parents. I got kicked out of my apartment. 45, I live with them every other night. Other nights I live on the street. And it gets to be a challenge. One of the things that I found so exciting about working on this is it actually used a fairly discrete data set, the Healthcare for the Homeless Registry, the city registry, to actually define this, which is a very different approach and one that is actually, I believe, much more reproducible.
And one of the limitations, too, of previous research is, along with the idea that research conducted within an ED setting is largely either walking around and doing self-report, or other administrative database studies have looked only for the ICD-9 code identifying lack of housing, the V60 code, which is very rarely used. When I first got all the ED sets, I went through specifically and just looked to see how many people actually were identified within the hospital setting as lack of housing. It was very, very few. It was a few handfuls across 11,000 individual patients. So again, not a reliable, and really you're going to undercount a population that already has a number of factors built into it where there's always the risk of undercounting. So again, we were just trying to add to the existing literature by doing something a little different, a little bit more systematic. And here's what we found. Lots going on here in this chart. You'll see some busy charts. We won't go too quickly, but we'll try to explain each one. You'll see that the yellow is not homeless and the blue is homeless. You can think about it in terms of happy and blue. If you're homeless, you tend to be more depressed, and if you're housed, you tend to be happier. So we'll try to use that as a color coding mechanism. What you'll have here, though, is that as you increase in frequency definition, going back to the idea that there's no common definition of what a frequent user is, if you are looking at people who just made 3 to 5 visits in calendar year 2005, you see a lot of people. You see 7,500 individual patients fit into that category, the vast majority of them not being homeless. As you progress, however, to the right, into higher categories of frequency of use, what you see are the proportion within each frequency category. So each frequency category, this adds to 100%, this adds to 100%. Within each frequency category, you will see the proportions of non-homeless patients consistently go down. You'll see the proportion of homelessness within those categories go up, to the point where at the top end of the scale, people making over 52 visits in a calendar year, that's once a week on average, while you only have 32 patients who are in that category, those 32 patients made 2,700 visits, and the vast majority of them were homeless. Now, again, what you see too is the idea that a few patients are making a disproportionate impact on ED volume. So while you have at the bottom end 31,000 visits, you can take a look that 32 people making 2,700 visits is about the same as the 58 people who made 2,200 visits, only visiting 31 to 50 times a year. And then as you go down the scale, you can make 113 people making 2,700 visits. So you're starting to take a look at a very small population making a significant increase. Did you?
And these are very different policy groups. If I look at this end, this is easy. 3 visits in the emergency department really isn't that hard to get to. If you come to me for an abscess, for a wound, I may say come back so I can check it again. Well, we just got 2 visits right there, right? So a third isn't that out of that extraordinary. Someone with congestive heart failure, someone with renal disease. This group is filled with that. This group will have very different policy solutions. If you say we have a problem here, our problem is we're not taking as good a care of this group as we might, then this group suggests looking at diagnoses and figuring out what sort of diagnostic associated interventions we can make. Perhaps in this group are kids with asthma, to pick up a recent city intervention regarding ED visits. On the other hand, that far end is a very different picture. People who are coming once a week, that's an individual picture. I can name quite a few of those folks and recognize them by face. That's an individual intervention. Most likely, we'll talk about different strategies.
What we did was we defined this at 10 visits or more. So you can see that the study population we're using are these last 4 categories to the right, those visiting 10 to 20, 21 to 30, and then up. That includes 888 patients making 16,000, almost 17,000 visits. So that's the population that we were looking at. Now, before we go on to the next slide, what's your thoughts about 888 patients? What percentage of them homeless, not homeless, would you say, looking at this graph? Would you think that maybe disproportionately homeless, disproportionately not homeless?
Disproportionately homeless.
Okay.
Let's take a vote. Who thinks that 80% or more of those folks are homeless? Okay, who thinks more than half are homeless? Who thinks a very small number are homeless? Who refuses to raise your hands in a public setting? For folks on the webinar, there was a smattering of folks who said more than 80%.
I might have missed this, but what definition did he use for homelessness?
So the definition, thank you for asking the question, is what definition was used. The definition is based on registration either with Healthcare for the Homeless or the Baltimore City Shelter Registry.
Correct. So this was a systematic way of identifying through various administrative databases what housing would be as a proxy measure.
Self-report, do they have definitions?
These are people who are actually staying in shelters. All Baltimore City publicly funded shelters are required to report their patient identifying information to the city. So the city maintains a shelter database.
So,
Regardless of the period they spent at the shelter or whatever.
Correct. And thank you for asking, because this is an important point to make. So it is possible that people who are in this study being identified as homeless would only need to have, theoretically, could have spent one night in the year in the shelter. They would have been counted homeless for the purposes of this study.
so it is very inclusive. The 23-year-old staying with his parents who got kicked out for one night and stayed in the shelter would be considered homeless in this definition.
In the end, what we had here, and we're going to revisit the proportion, by the way, we're going to answer your question in a second. So all three emergency departments had a total volume of nearly 160,000 visits. That includes everyone, people who went once, people who went 180 times. 160,000 visits from 96,000 patients. We've talked about 888 visited 10 times or more, so it's about 0.9% of all of the patients. But those 888 patients represented 10.5% of the entire ED visit volume. And that's important to remember. As a general rule of thumb, 1% are making 10% of the visit volume. So as a way of remembering that. And that 888 patients accumulated a little over $26.5 million in hospital ED charges, but that would also be inclusive of any subsequent inpatient stay that resulted from the ED visit. The hospital databases are not able to isolate the charges incurred in the ED separate from those charged upstairs once you get on the unit. So interpret that finding with that in mind. And then, so again, we were just taking a look at how these patients, with an emphasis on housing status. We have, and then just again, the hospital sites, just so that people don't think that maybe it's one of the three hospitals, maybe one is bearing a disproportionate homeless or patient burden than another. You'll see that the visits borne by homeless individuals are throughout our system. This is in all venues. So you can take a look and see of all homeless patients, it's about a third going to each venue, or the visits proportionately distributed across all venues. Again, you're not so much so with the non-homeless population, however, and again, interpret that in mind. The three emergency departments were Mercy Hospital, University, and Johns Hopkins Hospital.
You have numbers, total numbers. Oh, that was just your study, so it doesn't reflect total numbers. Okay, thank you.
Thank you.
The total volume is about 160,000 across the three hospitals in 2005. At this point, Hopkins sees, I believe, about 90,000 a year, 80 to 90, maybe 80 to 90. Mercy's around 60, and University is around 60. And all are 2005 data. All are steadily increasing between 2 to 8% a year.
In the end, out of the 888 patients, 455 were not homeless. 433 were homeless. It was virtually equal, which is an interesting stereotype to challenge. In even looking at the 10 plus users, you have a virtually 50-50 patient mix on housing status. A lot going on in this slide too. We'll just take a moment to illustrate. not to be too predictable, but the blues are for men and the pink and red is for women. Just in taking a look, the dark colors are for homelessness and the lighter shades of that are for non-homeless. But what you can see here is as you carve this out, you are not looking at an elderly population. And one of the policy points that you need to make in looking at frequent users is this an elderly population? Is this a Medicare population? Is this someone that you would expect to be perhaps in those last few years where you do tend to have more medical needs? And what this shows definitively is we are not talking about an elderly population. Instead, we're actually talking about a young population, 36 to 45, and then 46 to 55. And you're seeing both men and women. And so, again, from a policy perspective, this is important because the eligibility for our safety net program sometimes is predicated on things that gender would influence, such as moms with kids on Medicaid and some of the other issues. You'll see some spikes that are incidental across, like particularly non-homeless females in the 18 to 25. Can anyone guess what that might be? What might explain why women that young would be coming frequently to the ED? Pregnancy. And one of the things, pregnancy tests, pregnancy-related things, absolutely. And what you're seeing there is a lot of primary care given toward reproductive care. Which was interesting, but again, a completely different policy response than the traditional frequent user that you think about. So delving sometimes into those specifics kind of can help influence both the perspective of this population, but also our responses from a system standpoint as well. Let's take a look at insurance, because that tends to get a lot of attention in the policy perspective. Who's paying? According to this, everyone. This is not, and ED use has been shown in the literature as well and also is replicated here. This is not primarily an uninsured issue. And uninsurance has been shown not to be driving the ED utilization, the increase in the ED utilization we're seeing nationwide. While it certainly does contribute to it, it is not solely explaining anything. What you see here is a significant amount of Medicaid in the red. The self-pay or the uninsured is in yellow. You see Medicare actually in the blue. Virtually no private insurance of homeless population, and about 10% in the non-homeless population. And then the visits that represents is at the bottom. So about 6,500 visits that had an insurance code listed. There was about 800 visits or so that did not have insurance, so some missing variables. But for the most part, we're able to take a look at the mix of payers.
It points out a presupposition that is incorrect, which is this notion that this group is primarily uninsured. A significant portion is uninsured, but the majority is actually insured. Part of this may be because there's a large effort, especially when people are admitted, to get them insured. There's a significant incentive for any hospital to try to do that. And to some degree, it's effective.
But if we break that down a little bit more, in particular, just because we said that some eligibility tends to favor one gender or another, and in Maryland, like many states, a disproportionate number of people in that age bracket are women with children. So I thought, let's take a look at the insurance by gender. And one of the interesting things is to take a look at the number of men who are presenting on Medicaid. And that's significant because to be a man, particularly in that age bracket, to be qualifying for Medicaid, you have to be significantly disabled. That goes along with eligibility. And what you see here too, and challenging to the stereotype, is that you have both non-homeless and homeless men presenting with about 36 to 40% of their visits being charged to Medicaid. Now, the data does not allow me to know whether Medicaid or any of these payer groups actually paid the charges. I just know who actually was was going to be charged. So a fine point in the data, but I think for our purposes, and particularly a policy response, we can see. We also can see still, though, amongst men, you still have a high level of people who are uninsured, but then you also have Medicare throughout this for both men and women, which I think is significant as well. It's a point that is often left out of the policy discussions, is Medicare's role in being a payor for the frequent user population.
Two additional points regarding insurance. One I think is just important to recognize for everybody, which is in an emergency department, we operate under one federal law and one state law that essentially dictate what we do. The federal law is EMTALA, it's the Emergency Medicine Treatment and Labor Act. It says simply, we see all comers. We don't pause to ask about insurance. We don't pause to get a deposit. We see all comers. If we pause to ask about insurance before assessing whether or not there's emergent need, that is and should be illegal. So by and large, in treating people, certainly up front and usually for 90 or all the visit, I don't know what somebody's insurance status is. I can find out, but I don't know what it is. But that point, the second law that we work under is called the Prudent Layperson Law, and it's something actually in Maryland we have good reason to be proud of because we were the first state to do it, which says, back up a step, once upon a time there was a real challenge by insurers to say, well, you went to the emergency department, but it wasn't an emergency. What the prudent layperson does is defines emergency. And it says an emergency is whatever a prudent layperson says an emergency is. It's not what the insurance company says 3 weeks later. It's what you said it was at the time. And that's incredibly important. That's part of what maintains access to the emergency department. We work under those two legal structures. One of the things that this points out, though, is this anecdotal frustration by practitioners doesn't necessarily have to do with the sense of getting paid. This is an insured group. And I would be very hesitant to say that the frustration that people feel at a clinical level is because, well, they're not getting paid for the care. It's for some other reason. And I think that reason is that with this frequent user group is we're not doing what we want to do. We're not actually able to take care of people in the way they need, as defined by the fact that they keep coming back. We're not getting somewhere because our goal is not to have people come back over and over and over again. Our goal is to take care of people and be able to close out that episode of care. So at some level, this frequent use represents a failure on our parts, and that is psychologically disturbing.
The triage codes in particular, too, also get a lot of attention. Why is it that people are coming in and how acute are their visits? The stereotype, the anecdotal belief is that they're coming in and out all the time and it's for little insignificant trivial things and it's just taking up a space, but they don't really need to be here. And while that may be true on isolated cases, the data do not reflect that. The data actually reflects a fairly, if you go, for those who are not familiar with the triage codes, 1 is being most acute, needs to be seen immediately, within 10 minutes. Number 2, maybe within an hour. With number 3, maybe a few hours. 4s and 5s at the bottom. Sometime today, maybe run a few tests, a couple of things. And in the practice.
And let's add some perspective to this, okay? Triage category 1, dying. CPR in progress. The data is a little bit twisted because one of the emergency departments actually also puts people threatening suicide in that category. Level 2, really sick, having a heart attack. Need to be seen now. Having a stroke, need to be seen now. Level 3, abdominal pain, bad abdominal pain. Level 4, my ankle hurts. It might be sprained, it might be broken. Okay? Who thinks that's a reasonable emergency? Okay? Tripped and fell off the curb. I mean, I can tell you, Senator Mikulski thought it was an emergency. Okay? So I think it's an emergency, but that's a level 4. So least acute doesn't mean I'm not in pain and don't need treatment. 5 may be something like prescription refill. Okay? That one can be questioned too. I'm an asthmatic. I'm from out of town. I got into town today and I don't have my inhaler. Emergent? Non-emergent? Not going to ask you to vote, but put that in the back of your head that even a level 5 does not mean there's not something significant going on. So what is so impressive about this is you can read all kinds of articles about how emergency department visits are increasing because people don't need to go there. And what's always amazing is how much the literature argues against that, and this does too.
And then moving on then into who's paying for these low or high acuity visits. Now I grouped high is the 1s, 2s, and 3s, and then low is considered 4 and 5. So what we have here on the left are all the high acuity rates and all of the low acuity rates. You still see a tremendous amount payer mix, with the exception of private insurance not being present in the homeless population. But you see everyone is still paying for both low and high acuity. And I think that's important to remember, particularly from a policy standpoint, as different insurance types look at what they're going to reimburse and at what level. This is across all systems. 1, 2, and 3 was considered high, yes, thank you.
And triage levels do vary. The question is 1, 2, and 3 are high. It's for the purpose of the study, 1, 2, and 3 were high, 4 and 5 were considered low. There's a sort of national move toward a 5-level triage, but emergency departments definitely differ, both in their adoption of various systems as well as their actual application.
One of the other anecdotal assertions in interviews was frequent users, particularly the homeless folks, are coming in at night. They're using the ED as a de facto shelter. These are folks who normally are either not accepted at the shelters or for various reasons are unwilling or unable to go. And it's important to note, too, that there are very few, if any, Baltimore City shelters that are disabled accessible. So if you're in a wheelchair, there is not really options for you in the homeless services system. But that said, taking a look at the time of admission, what you're seeing here is a variant, and I should have gone back to my blue and yellow, but apparently missed that. So the red is not homeless, the blue is homeless, and you can see the difference, and even a few percentage points. What we have here is a range at the top here at your midnight group all the way on the right-hand side. At that 6%, you're talking about 494 visits in an hour. But then into a low at the 2%, the range goes down to 227 visits an hour. But the difference of 267 visits in those 4 percentage points is about 89 visits per venue per hour. And I think that that's from a volume throughput standpoint. And when the literature looks at ED frequency, you talk about input, throughput, and output. And that is going to be a significant volume that's going to bog down your throughput ability.
Yeah, the risk of tedious ED operational thoughts. This curve is a very normal curve. Busiest time in any emergency department is 11 a.m. to 11 p.m. This curve of, and this is the middle of the night right here, of this high volume overnight for that homeless frequent user group, that's the unusual part of this. Some of that may have to do with where shelter is otherwise available in the city, right? Things close at 2 a.m. Bars, restaurants pretty much close downtown at 2. This also suggests why some of the frustration comes overnight, because clearly there's that consistent frustration overnight and the relative volume changes. But the other thing it suggests from a policy and intervention perspective is this painful notion that if you want to try to do something about this, the time you got to do it is overnight. 7 a.m. to 5 p.m. or 7 a.m. to 3 p.m. probably isn't going to do much for you. And that makes any implementation that much harder.
And so when EDs are considering how they staff their social worker teams, making sure that people do have access overnight and on the weekends at that non-standard time is when you're seeing the presentation. So I think that that's important to think about from an administrative standpoint as well. But let's move on to people's clinical status and their presentation. We're looking at the first 5 primary diagnosis codes per visit. And one of the reasons that we'll demonstrate in a minute is that you can have a number of things going on, both acute and chronic, with a patient at any one time. Most of the literature only looks at the first diagnosis code. In practice, the first diagnosis code is what the physician will record as the patient's primary complaint. But you're going to miss all of the back stuff. So for instance, if someone was inebriated and fell and hit their head and they come into the ED, they get categorized as a head injury. The alcohol is not going to be captured, or if it's captured in the out codes. So this looks at the first 5 as a way of trying to be a little bit more inclusive in those back codes. And what we did was we averaged the 5 diagnoses. Now what you see here, and contrary to popular belief, overwhelmingly, these are for med-surg codes. These are med-surg visits. And as you would expect, particularly in a homeless frequent user population, you do have twice the amount of substance use, but everything else is not significantly different. Again, it challenges the beliefs of who the frequent user population is. At the same time, who here would believe that in a downtown Baltimore City frequent user population to the point where people are coming in 10 plus times in a calendar year, that this is the substance use codes. Does it strike you as accurate, at least in your experience, for those of you who are working in an ED, for those of you who may be doing research in this area? You think it's an underestimate? Anyone else working in an ED?
Well, I don't work in an ED. I work
Okay.
in a medical unit.
Okay.
But I think that people who use drugs are sicker and they do have medical surgical issues that may be a primary diagnosis. So it's believable for me.
Okay. One of the things that we were trying to do in interpreting the data as presenting to us is what confirms what you would think, or what opens up some questions that you might have about the data. And in particular, on the behavioral health codes, you've got issues of documentation. If it's not documented, if the doc didn't dictate that into the coding system and it didn't get coded into the visit, it's like it didn't happen and it wasn't present. And so while there are a lot of policy reasons that may influence how or what gets recorded and in what order, those are some issues that are going to have wide variance in practice. But this is what the data from the ED shows us on why people are coming in. I didn't know if you wanted to add into that. Okay. This backs up the idea of why you would use out codes. If I just took a look at the first diagnosis code, you're going to vastly underestimate the amount of substance use that's actually reflected in the back codes. So by being more inclusive, you are going to be capturing some more of particularly the mental health and substance use. But the substance use, the changes in the code as you move out on the diagnosis was actually most noticeable in the substance use. Co-occurring diagnosis gets a lot of attention and for good reason. What you have are patients presenting with complex medical needs, and the medical needs are co-occurring with behavioral health needs. Now, 2 of the 3 emergency departments included in this study have specifically a mental health unit. But when you take a look at the amount of mental health visits that are also coded on the same visit with a substance use code, you've got that Venn diagram of people who have got those co-occurring issues. And while this is complex to look at, in practice, you need integrated treatment. And one of the things that's a challenge for the health system is how do you have mental health care that can also accommodate substance users? And at the same time, how do you set up a substance use system that's able to do effective treatment when people also have mental health diagnoses? In the system, there tends to be a pointing a different direction. And people who have serious issues with both end up not being able to fit in either category. And so that becomes a challenge and a barrier for getting people into effective treatment. So it's important to be able to capture who these people are. The 601 visits that in the same visit had both a mental health and a substance use code. And I am assuming that that will be underreported just because of the challenges of doing the documentation, the recording, and the realities of an ED. But at the same time, and this was for all patients, both homeless and non-homeless, but the point is that the co-occurring was disproportionately homeless. 71% of those the COD visits were made by homeless patients. So in particular, this has real ramifications for the social work team in trying to connect a treatment that actually will work and meet the patient's presenting needs. I don't know if you had observations on some of...
The challenges of coding are throughout. And for the practitioner working, the code is typically the first few that are immediately pertinent. And I actually have a strong sense of undercoding, and that we will not tend to repeat alcohol use every single time unless that is one of the major things going on that visit. Which has ramifications, obviously, that when you're looking for funding, suddenly the numbers don't match up to reality.
Would you consider the substance abuse and mental health social needs for these patients? Because there's that factor of thinking of social needs being the driver of ED overcrowding. And did you consider those, where do you place those in the acuity graph you showed some time back?
So the question, if I make sure I understand, the question is how do mental health needs or substance abuse needs, how are those reflected in a triage score? Keep in mind, the whole purpose of triage is to say, I can't see everybody immediately, so let me rank people by how I'm going to see them. And the goal is the person who's most at risk of dying, I see first, and then we funnel down from there. So the actual substance abuse or mental health could fall anywhere within that rank. Okay? For example, I took too much heroin, I'm not breathing. That would be a 1 or 2. Okay? Going to die unless we do something. I stopped taking my heroin and I don't feel so well, my stomach hurts a whole lot, it might be withdrawal, it might be something else. That's a level 3. I took a lot of heroin, I stopped taking it this morning and I'd like to get off of it. I need help finding detox and I need help when the withdrawal starts, level 4 or 5. So substance abuse could be anywhere in that range, mental health could be anywhere in that range, and one of I think the most difficult things is there's clearly an interplay here. And teasing it out is challenging, but once it's teased out, it may alter your perspective so much that it's no longer realistic.
Another point to make too in this slide is, of all of the visits in the study, 16,700 or so, 25% of them have a code for some behavioral health, whether that's mental health, substance abuse, or co-occurring. And so I think that is also a takeaway point in meeting the needs of that frequent user population. It absolutely, by definition, has to include a behavioral health component in order to reflect, again, the data that we would have reason to believe would be a conservative estimate. Cycling. Now, this is a real issue and one that is not normally able to be tracked. We don't have a unified patient health system in Maryland nor in Baltimore City. But using the methodology that we had, which gets away from patient identifiers within individual hospital systems, instead we were able to unify all the patients and take a look at how many EDs that they had visited. And one of the things that we found was most interesting was that you can see the degree to which the use of all emergency departments differ drastically based on housing status. Now, these two bar graphs are 100%, and then these two. So interpret that within that rubric. But one of all of homeless populations, you've got differences in the low end of what we describe as frequent and then the higher end of what we describe as frequent. So we broke out 2 categories here now. We've got those that visited 10 to 20 times, and then we have ones that visited 21 times or more. So just to even break down the system a little bit further, and you can see the differences. What you have is, particularly in the higher end, the 21 plus category, again, while you're only talking about small numbers of patients, what you have is a 4-fold difference in how many of them went to 3 emergency departments. And also on the lower end, you've got 2-fold difference in that amount of cycling. Now here amongst the non-homeless population, you do have most people who are just going to 1 emergency department within that group. But you have significant, in the yellow, going to 2 emergency departments. From a policy perspective, this emphasizes how important it is that we move toward the medical electronic records. Now, we are doing that slowly but surely, and that will be coming, it's inevitability, but it emphasizes, too, in coordinating that care, how many different x-rays and how many different CAT scans and how all of the procedures that are repeated at every single one of these EDs, at some point, it's not an efficient use of resources from a system standpoint, and it also is not of any added benefit to the patient. And so, again, clinically as well as from a policy and system standpoint, there's a lot going on here that we really have to be aware of and currently don't have the system capability of being able to do that regularly. I want to be mindful of time. Charges, a lot goes on with charges. The data can be very willy-nilly in taking a look at what is a $1 emergency department visit, but yet that was reflected in the database. So, you have to take a look at where these charges come from, and remember that charges are very different than cost. So that's also one thing. This is per visit, and again, remember that this is also inclusive of any inpatient admission that may have gone along with that visit. But you can see just the mix, going back to our blue and yellow, the mix of per visit charges by patient group, and you can see that as you get toward the more expensive end, you see a more proportionate number of non-homeless patients, and you see on the lower end, particularly under $250, you see a greater proportion of homeless visits. But the takeaway is that over the course of the year, those cumulative visits made by homeless patients end up being more expensive toward the other end. And so it's that repetitive cumulative impact that volume brings with it. Let's also mention that when you were talking about these charges, in particular when you're talking about an uninsured population, we can look at ability to pay and the disincentive that people may have in seeking medical care if they're not able to pay, and all of the research that's gone into showing people's more chronic illness as they have delayed care, and what this means for meeting patients. When we're talking about a holistic perspective and you're talking about meeting patients' needs, their ability to pay is absolutely critical in consideration here.
And I would argue these numbers from two different directions. From an overall health system perspective, this isn't that much money. We spend 16% of our gross national product on healthcare. In the running of an emergency department, the bulk of this stuff is down here, and it's just not that much money. The reason to be concerned about this, the reason to take a look at these frequent users, and both the homeless and non-homeless group, is this is a group that we're not taking as good care of as we could. That's why they're frustrating, because somehow, at a societal level, at a professional level, we can do better for these people. However, from a policy perspective of I need to free money up to do something about this, oh my God, is it costing a lot? What the heck are we doing spending $50,000 when we could spend that money much better and take better care of this person? Right? So the clinical perspective, we need to take care of folks. From the policy perspective, and that's why the numbers are there, there's got to be money in this somewhere for actually doing a better job.
A couple of the limitations of the study, just to give you a perspective, and then interpreting the data that we've just gone over in clinical presentation to see this through. The methodology relies on accurate administrative entries. So again, when I'm relying on social security numbers and dates of birth and codes for race and gender, it does presuppose that on every visit that will be coded exactly the same, and the same in the shelters. And you're going to get a wide variety of quality control there. So to the best of our ability, we did the administrative matching, but you're always going to have some noise in how the data was entered and the ability to do that. This is limited to 3 downtown city emergency departments, and this may not be representative of the entire city's population. There are 11 EDs in the city, and so this only used 3. Again, we had talked a little bit about undercounting homeless patients, either because not all shelters put in, or not all homeless individuals use shelters. So again, you're going to be missing some folks, but it does at least provide a proxy. And then we discussed some of the problems identifying or defining what homelessness is. But let's take a look, let's personalize this a little bit more. Let's dig down a little bit more into the top 20 patients. Top 20 patients in this study made over 2,000 visits cumulatively. Our top person 185 times to an emergency department in 1 year. That's every other day. And with the range, the bottom range on the 20 being 67. 13 of them went to all 3 emergency departments with a mean age of 48, and 18 of the 20 were homeless. The homeless component was the single unifying or most common characteristic of that top 20 patients. And you can see the triage codes. Again, even for the folks that go every other day, you are not seeing a large number of the very low triage codes. Now, this could be for a variety of reasons, but it is not being coded as trivial. 20 people, $1 million at the end of the year. It's about $50,000 per patient. $50,000 per patient, and if they're homeless, we can get you a pretty good place for $50,000 with a live-in staff person. I mean, really, it's comic, actually, the misuse of resources, at least when it comes to meeting patients' needs. If someone's coming in 185 times in a year, clearly something is wrong there, and we need to figure out a way to make that right. So this, again, interpreting this across these 20 patients. But what you're seeing also is you've got a lot of chronic illness. Substance use, not too surprising. Hypertension, diabetes, HIV in 4 of the cases. Asthma in 5. These are the primary, the most commonly listed diagnosis ICD-9 codes that were affiliated with these 20 patients. And then you see still the insurance mix. Now, if you're self-pay, and you're still going to the emergency department a minimum of 67 times a year, what does that mean? in terms of ability to pay, resources for the states, all of the things that go into payer issues. And then how is it, particularly if you are uninsured, how is it that we talk about the solutions to the ED where there may not be financing mechanisms to that? And we'll talk about that in a minute.
And some of the themes here. So this is to give an individual perspective. Obviously, there are no names, and we're limited to what we can say, but the top user, 185 visits to 2 EDs, right around that average of 50,000 charges actually insured. Diagnoses included diabetes, hypertension, abdominal pain, fever, nausea, convulsions, upper respiratory infections, foot infections. So a pretty significant list. Similar, second person, HIV, respiratory infection, cough, chest pain. Right, so these two folks come in. It may be a visit for something to eat, or it may be a visit for significant illness. And separating those two out can be pretty hard because these folks have chronic underlying conditions.
I was mindful of time, so I was thinking that we would go through a couple more. The number 3 and the number 4 users as well. We've got middle-aged men, 168, 148 visits a year. Again, what is happening there that's not right? All 3 emergency departments, Medicaid user, about the range of 43 to 52%, and a range of the issues that diagnosis codes we had talked about before. But again, you're still seeing significant levels of high and medium triage codes. Now, the medium is that number 3 that we talked about before. So high is 1 and 2 in this instance. The medium is number 3. Low is 4 and 5. A couple of the conclusions that we drew from this study is that you can't assume that all frequent users are homeless, and you can't assume that all homeless users are uninsured. So that's some of the misconceptions that we wanted to try to push back against. It's interesting, too, how similar the clinical presentation is between these two groups. While absolutely homelessness presents other issues, both of these patient populations are high needs, acutely ill and chronically ill populations that do need to have their needs met in a better way. So it's not about simply just focusing on the homeless clients, although it is a distinguishing factor across a couple of characteristics and will influence what their needs are. It still challenges some of the prevailing stereotypes and assumptions. But that, again, the top 20 users make over 2,000 visits, and that was 12.3% of the study total, 1.3% of all of back to that 160,000 ED visits total. You've got 20 people making over 1% of the visits. Clearly, there can be some case management solutions there that would bring that down. So that gets us back to what's the real problem that we're looking at here. We started out by believing that the real problem was ED frequent users and overuse of the ED. But what this really challenges is that there's other questions we need to ask. Yeah, high ED utilization is certainly a problem, but what about unmet needs of frequent users? What about the prevalence of homelessness amongst that top-end group? Isn't that is clearly a problem that we need to ask here. Are all of these the problem, or is it something else? And so these are the questions that we ask ourselves in the what's next? What do you do now that you know all of this? How do you respond to this?
Should we flip to the questions, see where we go, and some of this may come up in the question and commentary. I think at this point, since we have about a half hour left, 25 minutes left, our initial plan had been to look at some recent literature, but let's see what comes up in people's questions and comments. And if we go, do you want to go to
I will flip through.
slide?
This is some of the recent literature that's been done here in Baltimore City and then nationally along a couple of things. But as we're maybe taking some questions, here are some tested solutions, though, that have been tried and shown to reduce ED use and better meet patient needs. And it might be that both people in the audience and people who are looking at this through the webcast can be responding perhaps to this list as well.
Do you want to put up the email, too? Or
oh.
You want to, and do you have anything? Or?
No, I just wanted to make sure that people have our...
This is the email address to send any questions that you might have if you're looking at this over the webcast.
And any comments or thoughts at this point?
Yesterday, I saw something on CNN. There was this guy who kept going to the ED because each time he called his doctor's office, they weren't ready to take him. And even though he had insurance, lack of access. How does that fit in all that?
I think that's beautiful. The comment is a story on CNN about a gentleman who kept going to the emergency department on account of calling his doctor's office, inability to get in, and therefore came to the emergency department. Sort of goes back to that initial question, why the emergency department? Well, why not? We're open. This bears that out, right? Half of this frequent user group, 10 or more visits in a year, was indeed homeless. A lot of them were insured. Half of that group was not homeless, and even more of them were insured. So clearly there is an access question. Also interesting, and wind up sneaking across here, maybe I should stay on this side. Here is one approach. I'm going to sneak on your side so I'm not standing in your limelight. This is Baltimore City, and this is something the city did that I think we all have reason to be proud of, because this was a very neat project that the city put together. It wasn't the emergency department. They decided to move back one step and look at EMS, the emergency medical systems, and calling ambulances. And they looked at their top 25 users, for various reasons brought that number down to 10, and said, what can we do to better serve these folks? And they got one case manager involved, primarily funded by the city. And what they discovered was the top person who called the ambulance was a diabetic who kept winding up hypoglycemic and really had no access to a regular physician, regular care to figure out how better to use her diabetes medications. And with that focused case management, her visits to the emergency department, or actually they weren't even visits to the emergency department because the ambulance would come out, treat her hypoglycemia, and then she wouldn't want to go to the hospital. Her visits dropped to almost zero. There were successes like that for 6 of the 10 people involved. Interestingly, the other thing that this effort pointed out is that for 4 of the 10, whatever the case manager tried to do, it didn't seem to make any difference. So there's sort of the group you could do something for and the group that is still not clear what we can do.
Do you have data on the people who frequently came, how many saw social workers or got into case management? And whether or not, I mean, you said 4 of the 10 people it didn't work for, but yeah.
Well, right, and this was an EMS effort. Do you mean for that or for in the, do we have any numbers on that? I don't think.
We do not, the data did not allow us to know what the interaction was in social work.
The 3 different hospitals have very different timing and availability of social work. Certainly, and Ms. Townsend can certainly comment on this, that I try to send her anybody that I can, and she graciously tries to do whatever she can. But the perspective of emergency department social work is similar to the perspective of emergency department overall. Our goal is crisis intervention. Our goal is to keep people alive first. So that role of trying to hook people up to services and then following up on it very quickly is outside of the effort of the emergency department. One of the elements of that city solution was that case manager went and saw these people at least once a week. And that was probably, to my mind, I don't have any evidence of this, to my mind, that was probably the most effective element. This very quickly, though, that sort of goal very quickly leaves the emergency department. And that's where it becomes a much broader challenge.
One of the tested solutions, in particular with the ED frequent user population, is specifically a range of case management services that is available outside the emergency department. And that's part of where we get hung up into some policy solutions, is that there's very rarely a reliable and steady funding source for the case management. In the 911 caller study that the city did, it worked great. And then the money ran out, and no longer, and then that's it. So now you have a new crop of frequent 911 callers. But so it worked great as a study and a pilot, and as most pilots do, they show great results. And then, okay, super, thanks so much for your report, and then that's the end of it. And so, but part of this is emphasizing how much of a systemic issue that this is, and taking a look too at some of the other tested solutions, identifying what the specific needs are, and then providing the case management to try to meet those needs. Case management can range from simply visiting or calling someone, having some contact with them, however minimal, all the way up to something very intensive to meet higher end needs. Now, looking at For instance, community resources that are able to do that and the limitations that are within the resources that are even allocated to do that are always changing and sometimes unreliable. But programs such as medical respite care capacity, if you're unfamiliar with medical respite, it's that subacute care where if you're in the hospital and you get discharged to home so that you can rest, for instance, pneumonia, broken limbs, wounds, similar things like that, no longer needing an acute hospital level care. But where do homeless people go? You can't discharge them to the street because it's not going to work. They're just going to come right back in, not to mention the fact that it complicates already serious medical injuries that they have. So medical respite is basically home care for homeless people, and it can look like a variety of things. Baltimore City has a 22-bed medical respite program affiliated with Mercy, I think. But that is affiliated also with a shelter. So it's basically a shelter where you don't have to leave. There's some light nursing and some case management and things that go along with that to help maintain people after they're discharged from the hospital, specifically to better meet their needs, reduce future hospitalizations, and ideally reduce ED visits as well. There are a number of these programs throughout the country that are very well studied, and they're documenting tremendous savings both in hospital inpatient costs as well as recurrent use of services and better patient outcomes. So that's one model that might be looked at as a solution to the ED system. Other supportive housing models across a range of intensity. And again, it can look like everything from just permanent housing, for instance. It seems people don't often think of housing as healthcare, but they are integrally related. And so even just permanent housing that is stable is really going to help stabilize a population if that's what their need is. You've got housing models, though, that can have a range of services incorporated into them, all the way up to like a housing first model where you're taking people right off the street with high intensive needs and putting them into housing, and then wrapping those intensive services into the housing unit as a way of stabilizing someone. Those models have also been shown to be tremendously cost effective, reducing future hospitalizations, ED costs, as well as use of other community resources that generally are affiliated with chronic homelessness, such as use of the jails and courts and police interaction and such. So again, there are a number of things that have been shown to work. But there's also some problems along with it. Number one being is that there's a lack of a funding mechanism. Medicaid doesn't pay for those, generally speaking. There's not that outpatient community level funding system that's been put in place that allows these programs to work. And so what happens is when we talk about that $50,000 a year for just that top 20, how can we be making better use of resources that are already being expended? We're all, I'm sure, well familiar with a fragmented system that we're working in. And so the challenges of an ED clinician, how is it that you can partner in a way that's realistic with all of the community needs that need to come together in order to make this work? It's not realistic. Dr. Schenkel can tell you, he's an ED physician. He's not a social worker. He's not in primary care. There are certain things that people are here in the system to do, but it's only meeting that one piece. And how is it need to be part of a whole that may not be present? Again, all of these things, real or perceived legal barriers to sharing information between providers, a tremendous concern. How is it that I'm liable if I'm sharing patient information? I might be absolutely perfectly willing to run my top list of users, but who can I give that to? Can I share that information with community caseworkers? Without that legal kind of guidance, you run into a couple of areas where people are reluctant to collaborate on a patient-specific level. I'm just going to continue talking, but we probably have some questions that are coming in as well.
Yeah, we do have a couple questions from our online audience. And this first one comes from the Center for Cancer Surveillance and Control at DHMH. And the question is, when performing cancer screening in the homeless population, one of the problems we encounter is tracking them for follow-up and giving them their results. Do you have any experience with tracking and performing follow-up with cancer screening results?
Not specifically. Thank you for the question. I have to say, it's bizarre to have something that's primarily over the web, and I'm so grateful to everybody who is here because it gives us someone to speak to, and knowing that there's this larger audience out in the ether too. So hello, all of you out there. Cancer screening, not specifically, but this question of how do you follow up, isn't just a problem with patients who happen to be homeless. I can tell you the primary follow-up that I do is for sexually transmitted disease. And I would say probably half the phone numbers that I have actually lead me to a phone that seems to be the phone of the person who it says it's the phone of in our records. It crosses a sexually transmitted disease, follow-up for radiology findings. We don't specifically do cancer screening in the emergency department, but I imagine the challenge is very similar. Ironically, in this population, this frequent use population, follow-up actually becomes easier because we'll see them again. And it is very easy. I can speak for our chart, but I think this is true of many electronic charts. It turns out to actually be very easy to highlight the chart and say, hey, the next time this person comes in, let's check on this. So that actually winds up being more straightforward. I can tell you a sort of interesting story. I don't know that it will help, which is that in a study of cocaine chest pain, which is chest pain and possible heart attacks caused by cocaine, they actually got a very high rate of follow-up by actually going to the known drug-using areas of the city. And they got very high follow-up with that. Similarly, within a homeless population, we get enormous support from the city's homeless efforts that they can actually go out and look for people. And a lot of times people will know folks. I can actually often call Healthcare for the Homeless and say, hey, will this person come by you guys? Because if they will, please follow up on this. I think what that points out is how essential it is to work with each other and to know the community and to be part of that community. And one of the great advantages we have, I think, as we tackle a challenging problem, is the tremendous goodwill of the folks who are involved with this care and the ability to talk to each other and to try the best we can to take the best possible care of patients.
Can I use it as a segue real quick too? In addition to having a number of systemic challenges, there are also challenges that rest with the patients and the way that they're presenting. When you do have patients who are morbidly or have a series of comorbidities, who have a series of behavioral health issues, who have homelessness as one of the unifying characteristics, what you're going to have is it brings with it a whole host of other things that make providing that care and meeting their needs to the point where referral and follow-up and all of that becomes much more complex. And patients' ability to, or willingness to engage with that is absolutely key. And sometimes you will have patients who, no matter what you do, like we talked about with the 9/11 study or the 911 study, if they're unwilling to engage, there is a limited amount of what you're going to do, even in the best system. So that has to be acknowledged as one piece of this, is that the patient has to participate. But recognizing that these are patients who have a series of crises going on in their lives that may make their health care secondary or tertiary as far as the crisis of that day, that week, that month, that year. And when you're not sure where you're going to be sleeping tonight, the fact that your blood pressure is off the chart is not really going to enter into it, and it becomes less important. If you don't know where you're going to be eating, then that becomes more important. Maintaining a diabetic regimen in soup kitchens and out of dumpsters and garbage bins, that is not going to work well with your health conditions. But so meeting people where they are. And when you also have limited literacy, you've got a medical cognition that may be a little bit different than the general population, you have to build that into your expectations of what's going to work. Being able to explain to a patient how they can manage their diabetes, if they do not understand what's being told to them and are able to actually repeat it back to you right then and there, you're going to have very limited success and you're going to be seeing them again tomorrow. So just having an appreciation of both the systemic and individual challenges that go along with making the solutions that we talked about work well. So I wanted to complete that circle at least so that it wasn't just the systemic challenges that we were looking at.
Okay. We have another question, and this is regarding opiate prescribing practices. What about the issue of opiate prescriptions given to patients in the ER? I work at a clinic for the homeless on Cape Cod, Massachusetts, and am tracking our patients' ER usage. Currently, about half of the patients are being prescribed opiates, which they cannot get from us, as we also have a Suboxone program.
Great. So the question is, I take it, how do we handle this whole question of narcotic pain medication? It's a big question. Could be its own talk, certainly. And I have no brilliant answers. It is complicated by several things. One is a push, and an appropriate push to take good care of people's pain. Unfortunately, the answers for pain medication are limited. In terms of actual medications, there's Tylenol, there are nonsteroidals like ibuprofen, and there are opiates. And those are the choices. On the other side of that, prescription opiate abuse is currently felt to be about twice as large as illegal narcotic addiction. I guess it's not exactly legal to abuse prescription opiates either. But it's an enormous problem. And how you tread that balance is a good question. I would add a third problem there, which is that for many of us in emergency departments, our DEA numbers and names are used fairly widely by people forging prescriptions, to the degree that Baltimore County actually has a 6 police unit looking into that. Those are the challenges. I don't have great answers. I can tell you in our department, part of the answer is to limit opioid prescriptions in order to try to handle that end of abuse. But on the side of trying to take care of people's pain, we also try to take care of people's pain and try to give appropriate medications to help them when they're in pain. I have no doubt that we err on both sides, but hopefully for the vast majority, we actually give them the medications that they need.
Other questions that have come in?
That's it for.
Questions in the audience? Yes, sir.
Just a simple question. On your list of proposed solutions, since we don't have enough money to do all of them, what's the base bang for the buck?
As always, it depends. It would depend on what the patient needs. Some of these patients probably could be managed fairly inexpensively through light case management. Given, however, their clinical presentations and the propensity of homelessness, I would say that you are, by definition, looking at housing models. So you have to incorporate how the housing model works, how it's funded, the staff that would be required to do the supportive services, and then weighing that against the foregone saved costs of future utilization. There are a number of studies that show that medical respite, for instance, saved 3 hospital systems in Los Angeles $3 million in the first 6 months that the program was offered. The Housing First programs are also showing tremendous savings across a variety of services in a community, even when you include the costs of the housing and staff along with it. But again, it would wholly depend on what the case, the specific patient would need. I don't know if you've got additional thoughts.
No, I think that's a great answer. Another answer, sort of an umbrella answer, is to recognize that the costs and the savings will not come from the same bucket.
Right.
And somehow at an overall level to reconcile that. I have no doubt that the Baltimore City EMS effort saved several emergency departments quite a bit of unreimbursed care. But because those are a public bucket and a private bucket, it would not be recognized. And somehow as we build and play with these models, we do have to recognize that.
And specifically in going back to the idea of a fragmented services system, investing in housing is a very different budget line item than investing in or saving in healthcare. And even though they are integrally related, they're budgeted very differently by very different departments, both federally, state, and local, as well as having completely different objectives. So again, streamlining that becomes challenging. But when it works well, and we have the outcome measures to show that in the peer-reviewed literature. Are there other questions? We have a few minutes left. Yes, sir.
Yeah, I'd like to say this is a superb presentation of a very interesting study.
Thank you.
Really great. Glad that I came here. The problem is not new. About 100 years ago, when I left these hallowed halls one day a week to work at the ER and pretend to be a real doctor again at Union Memorial, a patient came in for his 103rd admission. And the diagnosis was aspiration pneumonia, broken bones, acute gastritis. And obviously, the real cause, the real problem did not appear until you asked a few questions. And to point out the problem of emergency rooms, I asked the guy if he'd been a veteran, and he said yes. I said, do you really like your present life? He said, no, I hate it. I said, well, why don't you go out to Fort Howard? They have a program for alcoholics, and I paid the cab driver the money rather than giving it to the patient. And the problem is, did it work? I don't know. And that's the whole problem that you have in emergency rooms, the follow-up. You mentioned that some of these people come back. Yeah, this guy, we saw him, but did he come back again? I don't know. And it's a problem in ERs throughout the city.
Clinically, ERs anywhere, whether it's the frequent visitor or not, the feedback is a challenge in our field. The other thing, I love that story. Thank you for sharing it. Because the other thing that story points out so beautifully is at his 103rd visit, this gentleman was sick. And we all know that at some point, for all of these folks, at one of these visits, despite all of what may or may not have been crying wolf, often is not, they are going to be sick at some point. And it is our professional dedication to recognize that moment. And that makes it an enormous challenge. The other thing you point out so beautifully with that story is that homelessness and alcoholism were far down the problem list that day. There were much more acute needs. That was the acuity level 2. That was the, I'm not going to dictate. We're not going to see it in the record, that alcoholism and homelessness, because when I'm dictating that chart, those aren't even part of my thoughts. Those are the chronic problems where we have much more acute stuff going on. It's a beautiful story. Thank you.
One of the things, too, in keeping with the theme of this being specifically a public health grand rounds, in looking at this as a systemic issue, this is not simply a hospital or an ED issue. This, by definition, involves the public health community in being able to pool resources and enter into the kind of partnerships that make those tested solutions work well. And this is community health centers. This is local health departments. These are all of the providers that are out there in the public health community that are a piece of this. But there are a number of challenges that we need to try to work through in a systematic way to be able to overcome, in particular, the funding barriers often enough, but just some of the data sharing and other ways of making this work in a predictable, sustainable way. And I think it always frustrates us when we get involved in an exciting project. We show great results from a wonderful partnership, but then the grant funding or something runs out, and then, okay, well, and everybody goes back to doing it the way that our system has always done it, and that's frustrating too. So it seems like we're in this series of exchanged frustrations that does have a way out. It's just a matter of coming together as a community and pooling those resources to make that happen.
Okay, I think that our time is up. So I really want to thank both of our presenters so much for taking the time to be here with us today and share everything that you've learned, and I'm sure we all learned a lot. I'd like to thank everyone for coming, and I'd also urge you to join us again next month for our presentation on social marketing and public health, effective campaigns and how they work. On behalf of DHMH and the Mid-Atlantic Public Health Training Center, thank everybody for coming.
So, thank you.
Thank you.